A very good morning to all of you. I'd be taking you through the role of the femtosecond laser in flap creation. Though the femtosecond laser has now brought on the evolution of SMILE, when it was introduced in 2001, its primary role was that to create a flap and replace the microkeratome. The advantages of the femtosecond laser over the microkeratome were to give you a more customizable geometry and a more consistent and safer flap making process. Now, the femtosecond laser is a unique cutting tool because it is able to cut without causing much tissue damage in the surrounding tissues. That is because it delivers energy in very tiny quantums of time, which is 1 raised to the power minus 15 or a fem. When you're delivering energy over a short period of time, you basically need lesser energy, because the energy is delivered in very small areas in a very short amount of time. Therefore, with a lower amount of energy, you're able to produce photodisruption. Photodisruption causes the tissues to form a plasma, which is a gaseous bubble. As this gaseous bubble expands and collapses, it leaves behind a plane of tissue separation. Depending on how you're stacking the pulses, you can create horizontal, vertical, or even curved cuts, as you do in SMILE. Now, what connects the patient to the laser is a patient interface. This is the patient interface of a VisuMax or the Zeiss platform. You can either have a curved applanation or a flat applanation. So the Intralays and the Alcon system, as well as the Zima, have a planar applanation, but the VisuMax and the Femtech have a curved applanation system that they have. Once you're connected to the femtosecond laser, the laser will fire, and as a byproduct of photodisruption, you will see the opaque bubble layer or the OBL which is forming. So now you see here on the VisuMax, this is the flap being created. The central fixation light allows the patient to fixate, and it should be focused in the center of the pupil, allowing you to have a centralized flap. The side cut is performed, and once this procedure is over, you can manually lift the flap. Please remember that it is not a dissection like a microkeratome, because there are tissue bridges in between the areas of separation by the femtosecond laser. So in case of a worst case scenario where the laser has not fired adequately, you will not be getting a free flap or a buttonhole like a microkeratome. You can leave the patient as is about the procedure, and the patient is left from where the patient started. Now the femtosecond laser delivers energy to create OBL. You have to titrate the amount of energy that you need. If you use more energy than required, you risk having more inflammation, and using lesser energy makes the dissection much more difficult. With the higher frequency next generation femtosecond lasers, the energy requirement is less, because these higher frequency systems deliver energy in smaller durations of time. Also, the higher numerical aperture allows you to focus the spots more precisely, and therefore you're able to get more optimal results using lesser energy. Now, how that works is showcased in this video. Now you have the byproduct of the energy, the OBL. You see here a confluent white patch, which means that there is excessive OBL. You're using more energy than required. So though it'll be very simple to lift this flap up, you risk inflammation, DLK, and the consequences, and you should tone down the energy because it's unnecessary usage. This video will showcase a very smooth OBL, which is the ideal amount of energy. Now again, in this case, once the laser is firing, you will see here certain black spots or cold spots. This means that you're using lesser energy than required. So either you increase the energy, increase the spot size, or you reduce the spacing between the spots in order to get an optimal dissection. The advantage of a femtosecond laser over the microkeratome will be showcased in this video. This is with the Intralays platform, so you will have a different kind of patient interface here. Once you are latched on to the patient interface and applanating, the laser will fire. The previous pattern was a spiral pattern, which is seen with the Zeiss system. This is a raster pattern, which is seen with the Intralays. The pocket here that is created is to collect the OBL, And now the system starts firing in the raster pattern. In between, the laser has stopped due to some electrical or machinery issue. Now, this would have been an incomplete flap with a microkeratome, wherein you would have to abort the procedure. But with the femtosecond laser, you can go in with the same patient interface, redock. This time you don't need to keep the pocket on because the pocket is already created. And you can just retreat this patient, and the laser will fire this time through and through to create the flap. So this is the advantage of the femtosecond laser that makes the procedure safer and much more precise. So on the same patient, on the same day, now after the incomplete cut, you're going ahead and completing the cut. Now you will have the side cut which is forming. And once this is done, you, with the instruments, delineate the flap edge and then dissect the bed. This is the delineation of the flap edge. Once the flap edge is delineated, you take the instrument under the flap and you can lift the flap like you do normally. Once the stromal bed is exposed, the excimer laser can fire. Now, the femtosecond laser classically works best in optically clear media. This is a patient who has a small corneal opacity, and like Dr. Chitra had mentioned, that surface ablation is a good procedure for corneal opacity. However, this was a very faint opacity in the periphery, and this led to a vertical breakthrough. So once you lift up this flap, in the area of the vertical breakthrough, you will have a tear. So this is the area of the vertical breakthrough. We are lifting this flap up, and there will be a small peripheral island of tissue which will be left. Fortunately, this is a patient who's undergoing myopic correction, and you need the central area to be clear, and the island left here is quite peripheral. So we proceed with the ablation, following which the flap can be reposited. So once the ablation is done, the flap is reposited to be, you have to make sure that you align it as best as possible, and if you like, your bandage contact lens may also be placed. In this case, there is again, you will see here that there is an entrapment of the cilia that has happened between the patient interface and the eye. Now, because the cilia obstructs the optically clear passage, in the area below the cilia, there is a cold spot. That means the laser has not fired. So it's an uncut area. What you should do is you can abort this flap lifting or retreat, but this is what happens if you lift this flap. We have a tear running right through the center of the flap. You see here, there is a tear running right through the center of the flap. The flap is literally torn into two halves. However, the stromal bed fortunately was quite smooth and the ablation could be performed. The flap is then put on, trying to approximate the edge and the flap edge as well as the edge of the tear as much as possible. And then a bandage contact lens is applied. This patient did very well with a vision of 6/6. Now, this is again a small video showing you the OBL which is created like normally. Once the patient interface is removed, under the microscope you see here a small air bubble. Now, OBL, if extensive, which was seen in the earlier generation, or air bubbles, if too large, can interfere with the iris tracking. In this case, it's a very small air bubble, which possibly migrates through the trabecular meshwork into the anterior chamber. It's not really a nuisance. But if the OBL is too large, you have to wait for it to dissipate, stroke the stromal bed so that the iris tracking can go on. In this case, there was no interference, so the procedure is completed normally. All in all, the femtosecond laser gives you the opportunity to create planar flaps of uniform thickness and predictable thickness, and it does away with many complications related to microkeratomes, such as the free cap. The angles of the flap can be made more vertical or obtuse. This allows you to have a reduced risk of migration of the epithelium. It also makes the flaps snugly sit back and possibly reduce the risk of flap folds. these complications of increased DLK and rainbow glare, which were reported with femtosecond laser, were with the initial generation of low frequency lasers and are really not a concern. All said, the femtosecond laser, though a master flap creator, a flap still remains a flap, and the next leap really came with the blade-free, flap-free procedure, which Dr. Rupal will take us through. Thank you for your attention.